Thank you, Hira and John, for the invitation. And thanks very much to Professor Khan and Dr. Cherry and everyone else, and Dr. Aseni and everyone else on the call who supported the GENOS study. We're very grateful. And to Professor Hutchinson, but I have to say that because he's my boss. So I'm just going to, I mean, a lot of this has been covered already, but I'll just give a quick update on the global neurotrauma outcome study. So some of these figures have been presented already, but to me, the best study so far about the global burden of TBI worldwide is the Global Burden of Disease study, their analysis from 2016, which was published either this year or last year, and they estimate about 27 million cases of TBI happen per year, all TBI, severe, moderate, and mild. And about 10% of all deaths worldwide, this is from the GBD study as well, are due to injuries. So as Professor Hutchinson said, about 5 or 6 million deaths per year. And most deaths due to trauma are due to, well, either massive hemorrhage from thoracoabdominal, pelvic, or long bone wound, or due to TBI. A lot of them really are due to TBI. So it's a very large burden in terms of mortality and indeed morbidity. And we don't know exactly how many traumatic brain injuries require surgery because we don't really have data from low and middle income countries yet, but about 4% of those admitted in the US, this is from the US National Trauma Data Bank, will require surgery. So it's quite a large burden, and obviously that figure applies to the whole spectrum of TBI, including mild TBI. And so in severe and moderate TBI, it's a much higher proportion that requires surgery. So, I mean, in the GENOS study is really focusing, initially at least, on the surgical management of TBI, and it's long been known, there's many classic papers from the 80s and beyond that timely and appropriate surgical intervention for TBI is associated with a much more favorable outcome. And if you present more than 4 hours after the trauma or more than 2 hours after slipping into a coma, then your outcome is much worse following a trauma craniotomy for a acute subdural, like extradural, for example. And as we've already said, now multiple global surgery and global health organizations are starting to recognize that. And there's emerging evidence that actually, from groups like Harvard, that, that it's economically efficient to provide this service as well. So I think this slide has already been put up, but in essence, the GENOS study is a multi-center international prospective cohort study. Teams pick any 30-day period between the 1st of October last year and the 1st of October this year. So there's still plenty of time to participate and just collect data on all patients receiving emergency surgery for TBI during that time period and follow them up for 14 days. So for most sites, it's not a particularly onerous study to participate in. And teams consist of neurosurgeons, but also anesthetists, intensivists, who've supported our study an awful lot, as well as residents and medical students, many of whom have been instrumental in setting up the study at their institution. The study consists of two parts, really. So this is I just put up the data fields from the patient data set. I will just say, in addition to the patient data set, we also do ask sites to fill out a site questionnaire about the resources they have for the management of acute brain injury. And that includes things like, do you regularly have access to a mechanical ventilator for your severe TBIs? Do you have ICP monitoring? Do you have adequate pre-hospital care? Things like that. And that is, so far, of the sites that participated, produced quite an interesting set of results that haven't really been reported before. And just to highlight a few things on this, in addition to basic sort of demographic and epidemiological data, we've got quite a few fields here which pertain to pre-hospital care, which has already been highlighted as very important. And personally, I think is probably the great limiting step in terms of improving outcome from severe TBI or moderate and severe TBI. So to direct your attention, there's a couple fields on whether or not there is a pre-surgery episode of hypotension or hypoxia, which is obviously very important. And also the time to hospital, which is going to be one of the main determinants, as I've already said. There's a number of fields on operative data, and then the outcomes are fairly basic. It's survival to discharge or 14 days post-surgery, similar to that used in the CRASH study, which is the biggest study done on TBI so far, including low and middle income countries, and a number of other variables, including surgical site infection, ICU stay, but no long-term outcome. And I'll come back to that in a second. So, oops. Uh, so all this slide is just to highlight that all team members, so teams are 2 to 4 people at each institution, and all team members will be recognized as PubMed Citable collaborators on all publications resulting from the study, in the sort of to demonstrate this is a collaborative study more than anything else. And then this is just a quick oops, sorry. This is just a quick, oh, my mistake, sorry. Update on where we are so far. So 108 sites have signed up, 50 countries, 9 of which are in sub-Saharan Africa, 21 sites in total. It's quite a diverse range of sites we have. So about 5 come from what could be defined as conflict or post-conflict zones. So far Iraq, Syria, and Libya. And I highlight this because the data so far suggests that actually the countries in the world with the highest instance of traumatic brain injury and traumatic spinal cord injury, perhaps not surprisingly, are countries that currently have active conflicts. And this is from the Global Burden of Disease study as well. And as you can see, there's quite a good split of sites from both high, what are considered by the UN high human development index countries and low, medium or low human development index countries, which roughly maps to high versus low and middle income countries, or other ways of stratifying countries based on their development. And what's quite nice about this is, as has already been highlighted, actually there aren't many neurosurgeons in low and middle income countries. So to have a good representation, a good sample from both low and medium HDI index countries is something we're quite glad about. And this is just a map demonstrating roughly where sites are coming from. This is not quite up to date, but it does give you an idea of the spread of sites. So I said 108 sites or teams certainly have participated in data collection so far. About 56% have completed their study period, and about 700 patients have been entered into the database so far. So, and we're just about halfway through now, so we're quite hopeful we'll have quite a good sample size. And the point of this presentation isn't to present data from the study because it's ongoing, but just because this is a specifically neurosurgical presentation. I have put this slide up to just show the numbers of procedures, the numbers of each type of procedure that have been entered for interest more than anything else. The most common is evacuation of a supratentorial extradural hematoma, followed by an acute subdural hematoma. I would direct your attention, just because one of the next talks is Dr. Cherian presenting, that we do have about 20 cases of cysternostomy from different sites, and that's a very, could be a quite interesting aspect of the study, what we're excited about. In addition, there's also quite a few cases of what have been defined as exploratory burr holes, as in operating without a CT. Some of these are not truly exploratory burr holes. Some have been sort of burr holes for chronic subdural hematoma, for example, that have been incorrectly entered. But there are a few that genuinely are exploratory burr holes. And certainly my experience of working in Zambia, which is where I'm based at the moment, is that the vast majority of general surgical centers in this country, at least, working at sort of second level provincial hospitals, do still regularly perform exploratory burr holes. So it's a phenomenon that's worth studying, because at the moment it's particularly unregulated. And that's pretty much all I wanted to say. The only other thing I don't have a slide for that I want to highlight is that the GENOS study is a snapshot study, but we do want to, and have plans to, and are in the process of designing a longitudinal hospital-based registry for all admitted traumatic brain injury cases, called the GOTBI registry. And we're hopeful that the GENOS study will then progress on to this registry. And in that registry, we will hope to do things like collect robust long-term outcome data, both in terms of functional, neuropsychological, and economic data. But there's still plenty of time to sign up for the study. You can sign up at globalneurotrauma.com, or if you have any queries, you're welcome to email me on genos@globalneurotrauma.com, or I can answer questions now. But otherwise, thank you very much for the opportunity to present the study.
Thank you so much. Do we have any questions from the panel to be asked from Dr. Clarke regarding study participation? Any questions? Anyone having any troubles in signing up or something?
Well, I just have one comment.
Yes, please.
Yeah, well, Dave, yeah, thank you for the update. I noticed you said there are 21 sites from Sub-Saharan Africa, from 9 countries, right?
Yes.
Yes. So please, I will. Well, I'm the chair of the Young Neurosurgeon Committee of the Continental Association of African Neurosurgical Societies. So we've been encouraging the young neurosurgeons to participate in the GENOS study. As you know, trauma is mostly done by the young neurosurgeons and the residents in most of the countries. So I will appreciate if you could send to me the details, the countries that have already participated, so I can maybe try to follow up with the countries that have not yet maybe joined the study.
Yeah, thank you very much. Yeah, I'll do that as soon as the webinar is finished. But thank you. That would be fantastic.
Yes, you can contact Angelus. He can forward it to me. Yeah.
Yes, I'll email and CC both you in. But that would be wonderful because we're very keen of all regions to Sub-Saharan Africa is one that we'd really like to have participate.
Okay.
Thank you. Any more questions? Okay, so that's all.
I have a question.
Yes,
Here. One
yes,
question,
yes, John.
please.
Yeah.
Yeah. How many countries do you have participating? How many parties are participating now?
There's 108 sites or 108 teams. Some hospitals have sort of 2 teams participating, so probably about kind of 100 teams, and it's from 50 different countries.
Okay, so you're happy with the response?
We're quite happy, yes, but there's always room for more, and so yeah.
Okay, very good. Thank you.
Okay, thanks, John. Dr. Clarke, I have one small question if you're still there.
Yep.
Yeah, the thing is that when we are trying to get to participate, like I personally did that in Nepal with Professor Cherian Center. I was there, and there are a lot of troubles going through the, enrolling your center and then going through the ethics committee, because that is a big problem for most countries, especially in regions like Pakistan and in India, perhaps. In Nepal, we had some troubles going through that because it says that this is an audit and this is not a study which requires official approval. So if you could just highlight on this fact a little bit, and then we can start with Professor Chering. He's now here.
Yeah, it's a very fair point. I mean, because I'm based in Zambia at the moment, I organize the ethics for Cambridge, but also for Zambia.
Yeah.
It's much more difficult to get the study approved in Zambia than it is in Cambridge. So I do sympathize. I mean, I guess the barriers are, as you say, mostly this study in many jurisdictions will be considered research, so you'll need to go through the full ethical application, and we've not really got a way around that. The other thing is that some sites have reported is that there is a cost applying to ethics and in particular for an international collaborative study. So I think for studies in the future, certainly
that was a problem which we faced in like I personally faced that in Nepal when we were trying to seek approval for the GENOS. So like we had to go through a whole lot of process and go through a local body and then the national body. So it was, and despite the fact that it was said that this has been regarded as an audit rather than an original study. So this is a problem which is going on, and most in these countries where we already have problems with collection of data, then we have to go through added hurdles of having ethics review and all these things. So is there any way we can just?
I think the simple answer is unfortunately no. I mean, we still haven't. One of our main problems at the moment is we still haven't got approval from the Indian National Ethics Committee, the HMSC.
Yes.
And that's been a big problem because over 1 billion people, and many of our sites from their want to participate.
Yeah.
The only thing that can be said is that if we run a study like this, an iteration of a study like this in the future, at least we're aware of the sort of ethical barriers and can kind of account for that proactively. But no, it has been definitely, even from our end, it's been quite a struggle in some
Yeah.
jurisdictions.